Welcome. I am so glad you are here for this conversation. Today we are going to talk about something that sits at the very heart of nursing communication. This isn't just about talking, it's about connecting. It's about showing up, letting ourselves be seen, truly seen by our patients. By the end of our time together, you will understand the basic parts of communication. You will see the clear difference between communication that builds bridges, communication that builds walls. We will explore the tools you need to connect with all patients, even in the hardest moments. This knowledge is not just for your heart, it is essential for the NCLEX. The exam will ask you to choose the most therapeutic, the most empathetic response. It tests your ability to connect with courage. Think of communication as the lifeblood of patient care. It is the single most powerful tool we have in our nursing practice. Without it, our clinical skills, our knowledge, our best intentions can fall flat. Good communication builds trust. It reduces fear and it ensures safety. It is how we learn about our patient's story, their worries, their hopes. It is how we make them feel like a person, not just a diagnosis, not just a room number. Let's dive deeper into this beautiful, messy, essential process of communication. The sender is where everything starts. The sender has a need to express something, a thought, a feeling, a piece of information. The sender's responsibility is to be as clear as possible. It means choosing words that are honest and direct and paying attention to tone and body language. Are your arms crossed? Are you looking at the computer instead of the person? The sender's whole self is part of the initial message. The message is the what. It is the data, the feeling, the story. The words "I'm fine" can mean 1,000 things depending on tone. It includes body language and context. A message in a quiet private room feels very different from one shouted down a busy hallway. The receiver accepts the message. Their role is active and generous listening with their whole being. This means putting aside assumptions, judgments, internal chatter. Listen for the meaning behind the words. What is the feeling? What is the unmet need? Offering full, undivided attention is one of the most generous gifts we can give. Finally, feedback. Feedback is the receiver's response. I hear you. I see you. I understand what you are trying to share with me. Feedback closes the loop. It turns a one-way broadcast into a two-way conversation, the nod, the question, the shared glance. Without feedback, we talk into the void. With feedback, we build a living connection. This loop is a continuous flowing dance. It's a dynamic process that builds trust. NCLEX connection, choose the response that reflects, clarifies, or acknowledges feelings. Let's get very clear about what we are striving for. Effective communication is about connection. It is clear, direct, honest, and respectful. It makes the other person feel seen, heard, and valued. We are courageous enough to be clear about our intentions and needs while holding space for the other person's reality. It builds trust, promotes collaboration, and leads to better, safer patient outcomes. Active listening, empathy, clarity with simple language, respect, and feedback. NCT Nordsas Dashber, for example. This must be so difficult. Tell me more about what is worrying you the most. Ineffective communication is vague, indirect, dismissive, judgmental, or rushed. Imagine a patient says, "I'm really nervous about this procedure." An ineffective response is, "Oh, don't worry, it's very routine, you'll be fine." This dismisses feelings and shuts down the conversation. When we are not communicating effectively, we are building walls instead of bridges. NCLEX connection. Watch out for false reassurance, unsolicited advice, and medical jargon. Select the response that encourages elaboration and avoids advice or judgment. We might be talking, but not connecting. Without connection, we cannot truly honor the whole person. The best answer is the one that keeps the conversation open and therapeutic. Communication is so much more than the words we choose. First, verbal communication, spoken or written words, choosing the right words, speaking clearly, use language the patient understands. I'm going to give you this medication now. It is for your blood pressure. Nonverbal is incredibly powerful. Body language, posture, gestures, facial expressions, eye contact, a gentle touch can communicate more care than 1,000 words. Looking at the clock or avoiding eye contact signals impatience. Paraverbal is how we say it. Tone, pitch, volume, speed, same words, different meaning. Symbolic, images, art, and other symbols. For example, a doll to explain an injection to a child. Written, charting and discharge. Instructions must be clear, legible, accurate, electronic patient portals, telehealth, and secure messages. NCLEX connection. When verbal and nonverbal conflict, nonverbal cues outweigh verbal. If a patient verbally agrees but clenches fists and avoids eye contact, address the distress. Say, I notice you seem tense. Can you tell me what's on your mind? Verbal, nonverbal, paraverbal, written, electronic, symbolic. Use all intentionally. Mastering these layers makes your communication precise, compassionate, and test ready. Section 5, common barriers. Sometimes barriers get in the way of connection. Language barriers. Use a qualified medical interpreter, not family. Pain or discomfort blocks learning. Address pain first, then teach. Reduce noise and pull curtains for privacy. Say, this is important. Use plain language instead of hypertension. Say high blood pressure instead of NPO. Say nothing to eat or drink after midnight. With dementia, short sentences, one step at a time, gestures to support words. These thoughts are stop communication, giving advice, changing the subject, false reassurance, asking why, minimizing feelings. These are dismissive and harm the relationship. Advice puts us in control. Our job is to give information and support so patients choose. Changing the subject shows we won't sit with difficult emotions. Cliches invalidate pain. Why did you wait? Sounds accusatory. Ask, what was happening that made it difficult to come sooner? NCLEX, pick the option that addresses the immediate barrier first. If an option shuts the patient down, it's probably wrong. We build bridges with therapeutic communication. The first technique is using silence. Silence gives time to think, gather thoughts, and feel emotions. Offering self, I'll sit with you for a while. I'm going to stay here until your family arrives. Ask open-ended questions. What? How? Tell me about. Reflect. You sound very uncertain. Restate. You're worried about managing at home after surgery? I'm not sure I understand. Can you explain? And let's talk more about that feeling of being overwhelmed. NCLEX. The correct answer often uses open-ended questions, reflects feelings, uses silence, or offers self. Common styles: passive-aggressive, and assertive. Passive avoids needs. Aggressive violates others. Passive-aggressive is indirect. Assertive is respectful, clear, confident, the best. I understand you are feeling frustrated, but it is not okay for you to yell at me. We need to find a way to talk about this calmly. Adaptive techniques: simple language, visual aids, one-step instructions, repetition, and allowing extra time. Face older adults, speak clearly and lower pitch. For children, get to eye level and use play. With dementia, short, simple steps. Assume the unconscious can hear. For visual impairment, use clock face directions. NCLEX, Quick memory tool. Care, clarify and connect, ask open-ended questions, reflect and restate, empathize and explore. At the bedside, remove barriers first, use open-ended questions, listen more than talk, reflect feelings, and choose assertive, respectful language.